Morning to you, ladies and gentlemen. This is O.P. Yadav, Editor-in-Chief of Indian Journal of Thoracic and Cardiovascular Surgery, and we're reporting from the sidelines of the joint annual conference of the Asian Cardiovascular Surgical Society and Indian Association of Thoracic and Cardiovascular Surgery. It's indeed our singular privilege to play host to Professor Jai Raman. Welcome, Jai.
Thank you.
A long trip from Portland.
Thank you.
Professor Raman is Professor of Cardiothoracic Surgery at the OHSU in Portland, Oregon, USA. Jai, we have known your passion for innovation and cutting-edge technology, and the one I believe you are lately involved is named the dynamic chemical imaging. Would you like to tell us what is it in brief?
Okay, so if we can imagine having a set of lasers or light that we can shine into the tissue that gives us chemical signature of the tissue underneath, and use the data that we get from the reflected light or the reflected and absorbed spectra of light with light detectors and convert that with computation into an image that you would like to see under the microscope. So essentially, we're trying to replicate histology at the end of maybe a probe in the tissue underneath. And at present, as you know, if we have to do a biopsy, we take the tissue out, we soak it in formalin, we put it in a wax block, and then we make thin slices, stain it, and then you view it under the microscope, and it's done by a competent pathologist in the field, and then you get a diagnosis about 24 to 48 hours later. If we can do all of that with no tissue preparation, so initially we do it with tissue that's taken out, but within 90 seconds we have an automated diagnosis telling you that this is infarction, or this tissue is viable, it's got viable myocardium. That's the kind of thing that we're working on, and that's what I mean by dynamic chemical imaging, because it's dynamic. It's we're using a combination of chemical signatures and computation to get this, to arrive at this conclusion. But what's even better in terms of the potential of this technology is that it's automated. It takes away the variability of the pathologist. The second thing is it is capable, when we use a combination of infrared and Raman spectroscopy, we can actually look at small molecules, and we can look at metabolites. We can look at lactate, pyruvate, free fatty acids, glucose, simple protein structures. And so that gives you a sense of whether the tissue is alive, whether the tissue is dead, whether the tissue is at risk of dying, whether the tissue is at risk of further deterioration, all these things. So that is the dynamic component of it. And
is it a functional imaging, can I call that?
Yeah, it's a kind of functional pathology that we explore.
Functional pathology.
Yeah.
Okay, and we get a full metabolic profile of that?
Yes.
So would this be challenging things like FDG, PET and all?
Yes.
For diagnosis of viability and such issues?
Absolutely. So the thing is, the beauty of this eventually would be, at least as we try and iterate this and develop this into a viable, clinically applicable technique, is we will be using this intraoperatively to validate the technology. But as it gets further refined, you can envisage a time when we'll be using a probe, very much like the diathermy pencil on the tissue that will tell us what's underneath. I often tell people who are engineers, it's like a stud finder. When you go up against a wall, you use this thing to find where all the nails are.
Yeah.
It's a bit like that. But here we are trying to see what the tissue is doing underneath. So it gives you not just structure, but also function of the tissue. And the next phase would be miniaturization. Because it's all light-based, it's laser, we can miniaturize it in such a way that you could go down a catheter.
Okay.
So you could do, instead of doing an endomyocardial biopsy, you just go and put this up against the wall of the right ventricle on the inside and sort of map. It could be used to guide mapping in electrophysiology. And then if you want to take it down the bronchoscope, we could actually look at the edges of the bronchial epithelium and see if there are areas that are abnormal. It could be done in endoscopy as well. We are translating it in the cardiovascular space initially, and then hoping to move it to the lungs. Our collaborators in Champaign, in Urbana-Champaign at the University of Illinois, the engineering group there is focused on cancer, but focused predominantly on prostate, lung, prostate cancer, breast cancer, and colon cancer.
Can it be used besides diagnosis for prognostication?
Yes, that's the hope. So at present, what we're looking at, the simple low-hanging fruit that we're looking at is fibrosis. And fibrosis, as you know, is not good.
Yeah.
So what we're trying to understand is the patterns of fibrosis, and each tissue handles fibrosis differently. Each condition handles fibrosis differently. So if we have fibrosis along a certain pattern, which is disordered, then we know that this is likely to be bad. If it's periarterial fibrosis, there's got a different connotation. If it's interstitial fibrosis, a different connotation. And some of this, at least in the heart failure space, is going to give us a lot of data on prognostication.
Now, what is the evidence base that this technology is effective? Have we compared it to excisional biopsy and other standardized methods? And what is its sensitivity and specificity?
So that's what we're doing now. So we're actually comparing it to excisional biopsy, and all the early work so far in the cancer space, which has been done by my engineering colleagues, but in the cardiovascular space, what we've done is we've looked at it for transplant rejection, and it was highly specific and very sensitive, at over 90% on both sensitivity and specificity. We've looked at it for for comparing normal hearts with patients who have had VAD implants, and again, what we see in terms of histology is very specific and highly sensitive. But as we iterate and improve this technology and start including all the metabolic components, we're actually going in uncharted waters, because there is there's nothing that we have as a comparator. So what we're trying to do is use, we have collaborators at the Oregon State University in Corvallis that have, it's the Linus Pauling Institute, where they have a big expertise in metabolomics. So what we're doing is we do the diagnosis here with these technologies, and then we use the same tissue and send it to them so that they can get the metabolics.
So what stage of development is it? Is it approved by FDA?
No.
Is it available for clinical use?
At present, we have only 3 prototype devices. It's all been built at the engineering school at the University of Illinois.
So what do you foresee for a developing country like India? Cost is an important factor.
Absolutely.
So is it going to be a cost-effective solution, or just an addition of another costly exercise?
So at present, it's all, like I said, it's prototypes. But once we show the benefit of something like this, and you see the amount of time that is saved, and the amount of tissue preparation and invasion that is saved, then I think it'll be ubiquitous. It'll be everywhere.
Well, ladies and gentlemen, you just heard a trip into the future. Dynamic chemical imaging is an emerging modality. It's likely to replace, or at least challenge, the standard excisional biopsy, the standard way of looking at viability in terms of imaging, and a quick and an effective early answer on the operating table for viability, which can affect all kinds of surgery, be it arrhythmia, SVR, myocardial infarction, all those kind of things. So it's really a very exciting prospect. And thank you very much, Jay, for sharing your thoughts for this innovative technology.
Thank you.
Thank you very much.